year-old gentleman who presented to the outpatient clinic because of shortness of breath that has been going on for the past 2 weeks, but worsened today, which is why he's presenting to the outpatient clinic. Some of the other symptoms he's endorsing is a runny nose, a fever that, just a kind of subjective fever that he's noticed the past few days. And I'll stop there to get your thoughts.
Boss, go for it.
All right. Well, I think we have sort of a very common clinical concern here, which is shortness of breath. And then we have two really helpful modifying pieces of information. One of them is the tempo of the illness. And then the other one is the company that the shortness of breath keeps, right? If we zoom out and think about dyspnea overall, right, our sort of basic schema is going to prioritize heart, lungs, and everything else. And for the everything else category, we might think about sort of the three A's, right? Anemia, acidosis, anxiety, for example, right? But really the bulk of our cognitive energy is appropriately going to be invested into those first two layers, the heart and the lungs. And while sometimes the time course can help us distinguish the underlying etiology, the reality is that cardiac causes of dyspnea and pulmonary causes of dyspnea can present with anything from hyperacute presentation to chronic indolent presentation. So the tempo here doesn't necessarily help us distinguish between categories. What does help us distinguish between categories here, though, is the company that the shortness of breath is keeping, right? If we think about how we can delineate between cardiac causes of dyspnea and pulmonary causes of dyspnea, the two things that can be the most helpful that actually Robbie taught me is that you can have, if there is a syndrome of volume overload that accompanies the shortness of breath, it's going to drastically prioritize cardiac causes. Whereas if there's a syndrome of systemic inflammation that accompanies the shortness of breath, it's going to drastically prioritize pulmonary causes. In this case, we have some fevers, some rhinorrhea, and some things that are sort of suggesting that there is maybe some degree of systemic illness / upper respiratory tract illness. So that's pushing me to think of, okay, at this point, right, we're going to have to falsify the pulmonary cause, right? Now, that isn't to say that we can't have inflammatory cardiac causes of shortness of breath, for example, endocarditis. And sometimes we do have pulmonary diseases that are pre-existing, like the person who has COPD, who then develops heart failure later, right? So these aren't mutually exclusive categories, but I would say if we think about our basic schema of heart, lungs, everything else, we can look for the company that the shortness of breath keeps. And in this case, the inflammatory company that we have here is going to at least push me to think about investing most of my energy into understanding what pulmonary process could be going on, but not losing track of a potential cardiac process. Sharmise, what are your thoughts?
Absolute poetry. Absolutely. I think like when it comes to shortness of breath, in the 35-year-old patient, we're anchored by base rate of like it's the pulmonary process, and then we definitely don't want to lose sight of cardiac, and then see if there is any other signals for the other etiologies. It would be in a 35-year-old, just, as usual, pertinent to get an understanding of who this patient is, right? Like if it's a 35-year-old healthy, you would think like, oh, maybe infections, something like that. And then if for whatever reason, if this patient has any chronic lung diseases at the baseline, like cystic fibrosis, or is immunocompromised in any ways, then that's going to really have to make us think a little harder. And, the subjective fevers over the last, we all are used to using the one and only Dr. Rosa approach to inflammation. So kind of translating that to inflammation and kind of then thinking about the Venn diagram of inflammation plus shortness of breath. However, it's subjective. So I will hold on expending a lot of diagnostic energy until we get a little bit more information. But as Jack mentioned, thinking about lungs and the heart, getting more clarity on the inflammation in the background, and then go from there.
All right, beautiful. I love how you guys made so many warning points out of just the few words that I gave you. So a little bit more about the HPI. So he says that he's, other accompanying symptoms, he says that he's had a runny nose, no sore throat, no chest pain, no leg swelling that he's noted. When asked, what makes it better, he says that he has a history of asthma, so he tried to use his inhaler today, but it did not improve as it usually does. He normally uses his inhaler about kind of once a month as needed. And he tried it today, but it did not, it made the shortness of breath a little bit better, but it was still difficult for him to breathe, which is why he came to this outpatient clinic. He also has a cough that's been present for about the last 5 days. And he said it's been productive of some yellowish phlegm, he describes. No sick contacts, but when we dug into that a little bit more, he lives in a homeless shelter in San Francisco. So he said that there's, in his words, there's always people who are, who appear to be somewhat sick, but he can't kind of pinpoint anyone. In terms of the past medical history, so he has a past medical history of HIV infection, which was diagnosed about 10 years ago. It's well controlled. His last viral load was undetectable, and his CD4 count is 420. He takes Biktarvy for that. He also has a history of mild intermittent asthma. He, let's see, a little bit about his asthma history, he can't pinpoint any specific triggers for that. He takes a albuterol inhaler kind of as needed, and he, as I said, usually uses that once a month. No history, he has a history of hospitalizations from that asthma. I think he said that he's been hospitalized a total of 5 times in his life due to his asthma, but has never been intubated. And here, in terms of other medications, he takes risperidone for schizophrenia. And let's see if I have anything else here. In terms of social history, so he is unstably housed, lives in a homeless shelter in San Francisco. He uses methamphetamines. His use has decreased over the last month, but previously used it, 3 to 4 times a week, but in the last few months has cut down on that. So I will pause there.
Wow, such a rich HBI and history to discuss, Madalena. Thank you. So maybe I'll just take the rest of the HBI and then leave the rest for Jack to layer on. So I think the more getting more history about this patient, the cough that is productive, and it sounds like it's new prior history of asthma. I think for the most part now we're mostly focused on the pulmonary system without and then thinking a little less about cardiac. However, it's still on the differential. So when it comes to the pulmonary system and shortness of breath, I like an anatomical approach as well. So this patient already has a reason for a shortness of breath, right? He has history of asthma. We know it's been bad enough for him to have been hospitalized multiple times for asthma exacerbation. So an exam would be helpful. The fact that the albuterol hasn't helped doesn't exclude that it's asthma. If it's bad enough an exacerbation, maybe it's just albuterol is just not cutting it for him. However, even if you think it's an asthma exacerbation, you want to understand why it was triggered. So with airway disease, it's a URI that led to an asthma exacerbation, for example. Possibility, not 100% sure. The other thing is thinking about the parenchyma if there is an infection with a fever that is, he reported, are we dealing with a pneumonia, for example. Then also thinking about, your pleural reasons for pleural effusions that can cause shortness of breath, that a lot of the time can be cardiac. And then the other thing that I always try not to forget is the vessels themselves, especially with someone who has history of methamphetamine use. He's 35 years old, he's younger, but, pulmonary hypertension. And also the other thing that can happen to the vessels, they can get blocked. So The asthma tells me that this patient is more prone to be symptomatic from any causes of shortness of breath that can lead to an asthma exacerbation. However, that differential is going to remain broad, and I'll just have Jack layer on the history of HIV and everything else.
Amazing. I love it, Charmise. Thank you so much for that. I think, one of the challenges here is whenever we have somebody who has a known HIV infection, we have to sort of weigh the probability of Occam's razor against the possibility of this being a case of Hickham's dictum, right? We always want to look for the most simplified explanation for what could be causing these symptoms. But in an individual who is infected with HIV, we always have to be at least sensitive to the possibility of there potentially being multiple pathologies going on, or the possibility of this being an atypical presentation of a disease that we might frequently see or think about. The good news about this gentleman's underlying HIV is that it's very well controlled. We see that the viral load is undetectable, and the CD4 count is at a level that suggests a lack of substantial immune compromise, right? So then we have to ask ourselves a question: what types of pulmonary disease processes can present, or maybe a better way of asking it is to say which pulmonary diseases is this gentleman at increased risk for, despite the good control of his HIV and the normal CD4 count. And there are two types of infections, or at least two types of pulmonary infections, that individuals with HIV are at increased risk for, independent of their CD4 count. And those two infections are bacterial pneumonia as well as tuberculosis. Now, the risk of those two infections certainly goes up as the degree of immunocompromise progresses, but even in the HIV-infected individual who has a normal CD4 count and an undetectable viral load, they are at increased risk of bacterial pneumonia, particularly pneumococcal infections, as well as an increased risk of tuberculosis. Now, you might say to me, well, Jack, that's all good and well, but it seems like this individual just has the symptoms that would be the most compatible with an underlying respiratory viral infection. This doesn't really seem like TB. And that would be a very astute point to make, but we also have to temper that against the reality that individuals who have HIV are more likely to present atypically when they have pulmonary tuberculosis. Now, the probability of that atypical presentation again goes up as the CD4 count falls. But if we look at all individuals who are infected with HIV, they are more likely to present not with the typical subacute indolent upper lobe cavitary disease of pulmonary tuberculosis, but they may actually present with focal consolidation, ipsilateral lymphadenopathy, and other care features that look more like community-acquired pneumonia. And so if we ask ourselves, how does the presence of HIV, even though it is well controlled and there is a normal CD4 count, change the way we might approach this? We'll say the dominant energy is suggestive of an upper respiratory viral infection that is exacerbating some pre-existing lung disease, as Charmine brilliantly walked us through, right? That is where the bulk of our cognitive energy, it would be reasonable for that to go there. But then we have to also hold in the back of our mind the reality that this is an individual who is at an increased risk for bacterial pneumonia, and realize that the risk of pulmonary tuberculosis is there just by virtue of the HIV infection. And so that's going to give us a much lower threshold to think about testing for pulmonary tuberculosis in any individual who has HIV and is presenting with new inflammatory pulmonary symptoms. So I would say, if in most circumstances, I would say this is 95% likely to be an upper respiratory infection or an upper respiratory viral infection. I would say that in this case, maybe that comes down to 80%, and then or 70%, and then we're going to fill in the rest of that 30% of probability with some of these other things like a bacterial pneumonia, and then the small but non-zero chance of this being an index presentation of pulmonary tuberculosis, given that he, in addition to having HIV, we also see that he has risk factors, for example, living in close quarters with other individuals for a prolonged period of time. So the question becomes, how do we end up potentially teasing that out? And it's really going to rely on a few things. One, looking for any signs of pleural disease, as Charmine had mentioned, but then also getting a sense of trying to characterize the presence of any consolidative or nodular lung findings on a chest X-ray or potentially cross-sectional imaging.
All right. Okay. So many great thoughts here. So I will jump to the physical exam. Before I do, one other piece of history is that He said that prior to coming into this outpatient clinic at his homeless shelter, they tested him for COVID-19 infection, which was negative this morning. And I think he had also had prior COVID-19 infection a few months ago. Just wanted to get that additional piece of history. So in terms of the vitals, so he was afebrile. The heart rate was 88, blood pressure 125/85, respiratory rate 16, and he was sitting at 97% on room air. In general, he appeared very distressed and very anxious about his shortness of breath. He was able to talk in complete sentences. For HEEMT, unremarkable. For cardiovascular exam, regular rate and rhythm, no murmurs. For pulmonary exam, there were diffuse wheezing in all lung fields. The patient wasn't using any accessory muscles for breathing. Abdominal exam, soft, non-tender, non-distended. Neuro exam, non-focal. Extremities, there was also unremarkable, no edema, no putting edema. And I think I'll actually just pause here and wanting to get your thoughts. This is an outpatient setting, so how would you approach next steps and kind of any management at this time?
Sharmise, do you want to take this one? All right. So I think again, at this point, if we look at the features on physical exam that are really jumping out, I think anytime we see somebody who has any degree of respiratory distress, whether that's in the emergency room or in the ambulatory setting, right, we have to take that seriously. And so I think the fact that we have the sort of difficulty, just to clarify, was it unable to talk in complete sentences or able to talk in complete
sentences? He was
sentences?
able to talk in complete sentences. He just appeared very kind of anxious and distressed about the shortness of breath.
Okay. All right. So it's clear that this respiratory distress is causing a prominent degree of symptom burden for the patient. And so I think if we ask ourselves, well, what are the things that can really help us move the needle forward when we're evaluating the patient with shortness of breath? Oftentimes, once we get to this point in the exam, there's not much more, at least that I feel like my physical exam skills can help me characterize, right? We have wheezing on exam and we have some degree of respiratory distress. And so now it's about deciding how we're going to better characterize what could be happening in this individual's lungs. And again, we don't want to lose track of the possibility of underlying cardiac disease as well, right? We know that individuals who are younger generally tend not to present with cardiomyopathies, and individuals with HIV are at increased risk of developing either non-ischemic or ischemic cardiomyopathy. And we can see that not all things that wheeze are asthma or COPD. So for example, sometimes pulmonary edema can lead to congestion of the airways, and we can be faked out by the presence of wheezing on exam and think it represents an obstructive lung disease when it really actually does represent underlying pulmonary edema. So I think I would be focused on sort of getting possibly an EKG in this setting, looking for any evidence of prior ischemic events or ischemic disease, like if we see Q waves, but really putting the most of our effort into getting imaging of the chest. And I'll turn it over to Sharmise to talk through what some of our options there would be and which one she might lean towards.
Thanks, Jack. And yeah, Magdalena, that's a really, really great astute question about like, okay, you're in clinic, what you want to do. So, I love how Jack was like, okay, it kind of sounds like asthma exacerbation, but, we should be careful about not being, for another reason, for it not to be another reason for this patient to have reasons, or again, like trigger an asthma exacerbation. But in terms of like management, right now the patient's respiratory rate is normal. He's not taking a lot of shallow or using a lot of accessory muscles. He's sitting well on room air. I think in the chat, Alex made a great point of like, walking the patient. I think that's an excellent idea. The patient is currently at rest. So like walking a patient to see if there's any hypoxemia with ambulation is a really, really, really always use it as a good test of the severity of this patient's current presentation. And then also kind of thinking about who this patient is, right? You've already told me this patient had required 5 hospitalization for an asthma exacerbation. So that tells me that, this is someone that I should be thinking very carefully through. What can we do in the clinic? one helpful tool is like measuring a peak expiratory flow, especially if they've had that in the past. I think about like 20 or something % reduction. You're like, okay, this is definitely an exacerbation. However, I'm kind of getting the feeling that for this patient, it's going to be decreased because of just the diffuse wheezing that he's having and how symptomatic and anxious he is about that. The other things to do, in clinic, you can give them either an albuterol nebulizer if it's possible, or an MDI with a spacer that I think both of them have good efficacy together, and see if there's any benefit from that. And the other question is like, we're assuming this is like an acute exacerbation. However, in someone who's had 5 hospitalizations is only on an albuterol inhaler, it kind of tells me that maybe their underlying disease is also not very well controlled. So for now, I think I would give him some albuterol inhaler, try to walk him and see how he's doing, see how he feels afterwards. And then thinking about like, oh, is this patient stable enough for him to get a chest X-ray, get maybe some lab work, we can do ECG in the clinic, and then reassess to see if this is someone who needs to go to the emergency room, or we can treat that as an outpatient asthma exacerbation with a close follow-up.
Yeah, I love how what you guys are discussing kind of mirrored exactly what we were trying to figure out in the clinic, really how severe is this patient? Do we need to send him to the ED or not? Especially given some of his risk factors. So, I think it was Alice who put this in the chat. So we wanted to get labs and to get a chest X-ray. So we kind of walked him to where he got his lab work, and his SpO2 stayed at, 97%. So he was able to walk, without any problems there. So labs were drawn. While those were pending, we got a member of the team to walk him to imaging. So we got a chest X-ray, because really the concern at this point is, was this an asthma exacerbation or was this a pneumonia? So we got the chest X-ray. About an hour later, that came back as clear. And after he had, actually prior to him going to get the imaging, Charmaine, exactly as you said, we gave him an albuterol and ipratropium nebulizer. And after completing that, the patient's symptoms had significantly improved. So I will pause there. So the labs have been drawn when they hadn't returned at this point, but I'll just pause there with that data and see kind of what next steps you would take, treatment, things like that.
That was, thank you so much, Madonna. Very helpful information to have. And I feel like the fact that he's feeling better with albuterol and IPRA is a good sign that, again, like we think about our diagnosis, like, oh yeah, we're worried about asthma exacerbation. He's doing better while we figuring out what the trigger is. And it sounds like with the clear chest texture, pneumonia is a little less likely. The other thing, with the cough, the URI symptoms, you want to think about, like, again, viral etiologies. I know COVID is negative, but you can also think about like sending a respiratory viral panel now to think about like, oh, was this the viral URI that triggered an asthma exacerbation, which tends to be a common etiology for our patients getting asthma exacerbation. I would probably monitor this patient for a little longer in clinic, just to see how he does. And then the question becomes like, while your labs come back, then thinking about like, oh, if this is someone that you can send out with just an asthma exacerbation, so steroids, more inhalers, with a close follow-up and a close condition, like, hey, if you're not feeling better, go to the emergency room. Or, if he starts declining pretty fast, like if he just gets immediate relief from the inhalers, from the nib treatment, but like, a few minutes later, he's still more symptomatic and he needs more frequent treatment. The other thing that I would just remember with like asthma exacerbation, if people start taking, a good thing to continue to monitor the exams, because sometimes what can happen is that people can tire out, so they get they start taking shower breaths, so you don't really hear wheezing. That's not a good sign. That is actually means like they're tiring out, they're becoming more hypercarbic. So the things to watch out for is like if they're getting like a little bit more altered, they're taking shower breaths, that you don't hear the wheezes anymore. That is like emergency room now type of a situation. Jack, any other thoughts from you?
I have absolutely nothing to add here. I think that was phenomenal. I'll turn it back over to you, Madeline.
Yeah, so you guys were spot on. So this was at the kind of at the tail end of the clinic day. So the thought was that this was an asthma exacerbation, and there was a lot of thought as to how to manage this. And so ultimately, the providers decided to prescribe inhaled steroids along with his kind of the albuterol inhaler as needed. We had the discussion about you can use, I guess there's some indications for oral steroids, but he, has this, he's on risperidone, and I think we ended up not going with that for a few reasons, but one of that was that the oral steroids could potentially make the, his schizophrenia challenges more difficult. And what else do we have? I was gonna say one more thing. Oh yeah, and so we were talking about some of the triggers, and one of the things I learned is that the patient didn't report any specific triggers for his asthma, but I learned from one of the providers that more than 80% of infectious triggers are viral for asthma exacerbation. So I think the thought here was that it was kind of a viral infection triggering this asthma exacerbation. So he was prescribed, this inhaled steroid along with his albuterol, and then planning for close follow-up.
I have loved this case so much, Madalena. Thank you so much for presenting it, because when I always like, my spiel is like any case is a good case. Like there's just so much to discuss about like management, like when would you send someone to the ED, which one wouldn't, like how do you reason through that? So both like I think diagnostic reasoning is so valuable in a condition that we see often, and also like thinking more about like the therapeutic reasoning and how to manage. So I thoroughly enjoyed this. Thank you, Madalena. I hope the patient did well.
Yeah, I echo that 1,000%. I think there is so much nuance in even the basic. There are so many different flavors of these common illness presentations, and I appreciate you highlighting this for us, Madalena, here today. And I think this really also highlights that whenever we're making decisions amidst some degree of clinical uncertainty, the diagnostic test of time and the diagnostic test of therapeutic interventions can oftentimes be our most powerful here, right? The two things that are probably going to help us really solidify that this is indeed purely an underlying asthma exacerbation from a viral upper respiratory infection is it the empiric therapy and then seeing how the patient responds. And sometimes, right, we are encountering this case at a single moment in time, but how this unfolds over the next 3, 5, 7 days from here will be even more useful diagnostic information. And so while we're saying that this is our presumptive diagnosis now, the journey with this case doesn't necessarily end. And we may see that, the symptoms completely resolved, or things may fail to improve as expected. And that in and of itself is a powerful diagnostic test for us to either say, okay, we can close the book on this one, or we need to reframe and reevaluate here. So thank you for showing us the sort of overlap. Charmaine, I think you put it brilliantly, of the sort of TX and DX reasoning here.
Yeah, I totally echo that. I loved how you walked through both the reasoning, not only of diagnosis, but of which tests you would get, especially in an outpatient setting. And yeah, really appreciated your teaching. Thank you both.
All right, Deborah, we'll kick it over to you to bring us home with some teaching points today.
Hi, everyone. Great case. Thank you, Madalena. So in this case, we had the patient with shortness of breath. So we think about the tempo that could really help us, and the causes that we think more, it's about in the heart or the lungs. That could be something valvular, could be a heart failure, a heart attack, or arrhythmia. In this case, the patient had inflammation, so was more suggested of something in the lung. And we think about if the patient is healthy, that could be an infection, of if the patient has a chronic disease, that could be a COPD or asthma exacerbation. And looking for the lungs, we look for the parenchyma, that could be an infection, the pleural, that could be an effusion, the vessels, that could be a pulmonary hypertension or a block. And the patient is HIV positive, so we think what types of disease can present with normal CD4, could be bacteria, pneumonia, and TB. And any patient with HIV need to be tested for the TB. And the respiratory distress could be like for could be another cause, that could be it's a pulmonary edema that can congest the airway. So we can check the patient asking for walk and checking the expiratory flow and given the albuterol and check how the patient react. And then doing some tests like an EKG and an image. And in this case, the patient had like a asthma exacerbation. So as Jack said, we need to check the patients in a few days to see if the symptoms will improve or not. So thank you, everyone. See you all tomorrow.
Bye, everyone.
Thanks so much, everyone. See y'all later.